All right, let's jump right into this. Welcome, everyone, to today's Daily Coding Explainer, where we're going to take all that guesswork right out of the guidelines. Today, we're tackling a very specific and, honestly, a highly audited medical scenario that involves multiple overlapping conditions. We're going to break it down and translate it into clear, manageable logic. So if you've ever felt tripped up, or worse, had a claim denied because multiple systemic diseases popped up in a single patient's chart, well, you are in exactly the right place. We're looking at a case today that involves both the renal system and the cardiovascular system, and we're going to see exactly how the coding guidelines uniquely link them together. So let's put your skills to the test right off the bat with a real-world scenario. I'm going to read this prompt aloud, and I want you to read along and mentally formulate your own answer before we reveal the solution. Ready? Here we go. A 72-year-old patient is treated for hypertension and ESRD. The patient is hemodialysis dependent. How is the diagnosis coded? I'm going to give you just a brief second to lock in your thoughts. Seriously, think about the conditions, think about the sequencing, and try to recall the specific guidelines that apply to those exact keywords. Okay, let's see how you did. Here is your correct coding sequence. We've got 3 distinct codes here. First up, I12.0 for hypertensive chronic kidney disease. Second, N18.6 for end-stage renal disease. And third, Z99.2 for dependence on hemodialysis. Did you get it? Now, what's really fascinating about this specific combination is how these 3 codes completely tell the clinical story of this patient. We don't just have random codes thrown together willy-nilly. There is a very strict hierarchy and a relationship dictated by the coding guidelines that literally forces us into this exact sequence. Now, before we really unpack the step-by-step logic of exactly why this is the correct answer, I want to take a super quick pause. If you're finding value in this structured approach to medical coding, please go ahead and hit that like button on this explainer, and definitely subscribe to my YouTube channel. Doing that guarantees you'll never miss out on these daily medical coding breakdowns, and honestly, it really helps us keep bringing this focused education straight to you every single day. Okay, let's get back into it. To truly understand why this sequence is mandatory, let's walk through the exact logic flow you need to memorize. Think of it like a puzzle. Step 1. The guidelines tell us we have to assign a code from the I12 category, that's hypertensive chronic kidney disease, whenever both hypertension and a condition classifiable to category N18, which is chronic kidney disease, are present. Step 2. Once you've established that I12 combination code, you absolutely must assign a code from the N18 category to identify the specific stage of the CKD. In our patient's case, that stage is ESRD, which gives us N18.6. And finally, step 3, we assign Z99.2 for the documented hemodialysis dependence. Do you see how each code completely relies on the previous one to paint the full picture? You literally cannot have step 2 without step 1, and step 3 provides that absolutely crucial final detail of the patient's current treatment status. So the really crucial point here is understanding the clinical implication of ESRD within the coding universe. End-stage renal disease inherently implies that the patient receives treatment in the form of hemodialysis. The guidelines are super specific here. Because ESRD implies this heavy level of intervention, if the hemodialysis is explicitly documented in the chart, you are required to code for both the stage of the CKD, which we did with N18.6, and the dependence on hemodialysis, which we did with Z99.2. You don't just assume the dialysis code is redundant. No way. The rules mandate that we capture that documented dependence to fully reflect the sheer complexity of the patient's care. Now, I want to draw your attention to a specific directive straight from the guidelines, because this right here is the golden rule that ties step 1 all together. That automatic linking of hypertension and chronic kidney disease under that single I12 combination code happens automatically, unless the provider documents the conditions as unrelated. I want you to burn this phrase into your memory. As coders, we must always assume that hypertension and chronic kidney disease are related, and therefore they require that I12 category code, unless the medical provider explicitly states in the medical record that they are not related. Basically, if the chart is totally silent on the relationship, the guidelines make the connection for you. And that brings us to a really important final question to truly test your mastery of this whole concept. What if the documentation completely failed to mention hemodialysis dependence? How would your final code assignment change? Think about what we just discussed regarding ESRD implying dialysis, but balancing that with a requirement for it to actually be documented to assign that Z code. Missing documentation completely alters your coding accuracy. I'm going to leave you to ponder that scenario because it's exactly the kind of real-world nuance we're going to continue to tackle in tomorrow's daily update. So keep studying, keep laser focus on those guidelines, and I will see you in the next explainer.